This recording will go over impetigo, candidiasis, and tinea infections. Impetigo often occurs as a secondary infection from another skin lesion, such as an insect bite. Close contact contributes to the spread of impetigo, which is highly contagious. Children in daycare facilities, schools, or camps, and adolescent athletes are at increased risk. The incubation period for impetigo is 7 to 10 days, and it can spread to other parts of the child's skin or to others who touch the child, use the same towel, or drink from the same glass. Spread of the infection is fostered by poor hygiene, crowded living conditions, and a hot, humid environment. Lesions resolve in 12 to 14 days with treatment. Staphylococcus aureus is the primary pathogen in most cases. Impetigo begins in an area of broken skin, such as an insect bite, scabies, or atopic dermatitis. The break in the skin allows for organism entry. The inflammatory process results in the formation of a pustular lesion. Honey-colored fluid from these lesions become crusted. In some children, nasal discharge containing the organism erodes healthy skin above the upper lip, allowing for organism entry. The primary lesions of impetigo occur in two forms: bullous impetigo or non-bullous crusted impetigo. Bullous impetigo characteristically manifests as small vesicles that can progress to bullae. The lesions are initially filled with serous fluid that later become pustular. The bullae rapidly rupture, leaving a shiny, lacquered-appearing lesion surrounded by a scaly rim. Crusted, non-bullous impetigo appears initially as a vesicle or pustule that ruptures to become erosion with an overlay of honey-colored crusts. The erosions bleed easily when crusts are removed. Lesions are mildly pruritic. Scarring is uncommon but can occur if the child picks or scratches the lesions. Post-inflammatory hyperpigmentation is a frequent sequela in dark-skinned children. The lesions are often located around the mouth and nose but can appear on any part of the body. The characteristic appearance of the lesions usually confirms the diagnosis. Impetigo is treated with topical and oral antibiotics. Severe cases are treated with IV antibiotics. The lesions should be gently washed 3 times a day with a warm, soapy washcloth, and the crust soaked and carefully removed. A topical ointment or a topical antibiotic ointment can then be applied. Good hand washing and careful hygiene are imperative to prevent the spread of infection and should be emphasized to the child and parents. The child should not attend school or daycare for 24 hours after beginning treatment. The school should be notified of the diagnosis. Important teaching for parents caring for a child with impetigo include that the child can spread impetigo lesions merely by touching another part of the skin after scratching the infected area. It's important to keep the child's fingernails short and wash the child's hands frequently with antibacterial soap. The caregiver should emphasize good hand washing and careful hygiene for the child's entire household. Discourage family members from sharing towels, combs, or eating utensils with the infected child. Please review the purple nursing care box for the child with impetigo on your own. Thrush, which is oral candidiasis, is a superficial fungal infection of the oral mucous membranes that is common in infants. Thrush occurs as a result of overgrowth of Candida albicans. In addition to oral lesions, the child may exhibit lesions in the diaper area, which are caused by Candida albicans passing through the intestine. Moisture and heat in the diaper area create an environment favorable to the development of Candida dermatitis. Persistent candidiasis suggests that the child might be immunocompromised. A neonate can acquire candidiasis during delivery when passing through an infected vagina. An older infant can have a fungal overgrowth as a result of immunosuppression during antibiotic therapy, from exposure to the mother's infected breast, or from unclean bottles and pacifiers. Candidiasis occurs most often in infants. Predisposing factors in all age groups include antibiotic therapy, diabetes, and altered immune status. White curd-like plaques are noted on the tongue, gums, and buccal mucosa in children with thrush. They can be distinguished from milk curds by the difficulty encountered in removing them and the bleeding of the erythematous base when plaques are removed. A child with severe infection may have difficulty eating. The lesions of Candida diaper dermatitis are usually bright red and coalesce, with some satellite lesions spreading out to the child's abdomen and thighs. The diagnosis of thrush and candidal diaper dermatitis is made from the clinical appearance of the lesions. Nystatin oral suspension swabbed onto the mucous membranes of the mouth is effective in treating thrush. Because cotton-tipped applicators tend to absorb the medication, a more effective method of administration is to rub the suspension onto the mucous membranes with a gloved finger. To increase the amount of time the medication is in contact with the mucous membranes, nystatin should be applied after feedings. Because Candida is present in the GI tract, oral nystatin is often prescribed to decrease the likelihood of recurrence. Oral fluconazole is an alternative therapy. Candidal diaper dermatitis is treated with a topical antifungal agent such as nystatin. Pacifiers, nipples, and bottles should be thoroughly cleaned to decrease the chance of reinfection. Teach the parents the technique and importance of good hand hygiene. If the child is breastfed, the mother's breast should also be treated with nystatin. Suggest small, frequent feedings for the infant or child with thrush who is uncomfortable. Cool liquids are soothing to the older child. For the infant with candidal diaper dermatitis, suggest that the parent apply nystatin or another antifungal cream and leave the diaper area exposed to air to help reduce the moisture that facilitates fungal growth. Advise the parent to contact the healthcare provider if the infant refuses to eat or fever develops or if the candidiasis does not clear with treatment. Please review the purple nursing care box for the child with candidiasis on your own. Tinea infections are fungal infections that can invade the hair, skin, or nails. Based on the name of the infection, Tinea capitis, it tells you where the fungal infection is. For Tinea capitis, it's the scalp. Tinea pedis, it's the feet. Clinical manifestations of Tinea capitis include erythema and scaling of the scalp and one or more round patches of alopecia that slowly increase in size. In some cases, thick broken hairs close to the scalp surface results in patches of black dotted alopecia. Tinea corporis, commonly seen on the trunk, face, and extremities, is also known as ringworm. It is characterized by ring-like plaques with clear centers and scaly red margins. Lesions are usually 1/2 to 1 inch in diameter and mildly pruritic. Manifestations of Tinea cruris include pink papules and scales on the inner thighs, groin, scrotum, and buttocks. This is also known as jock itch. Pruritus is also present. Finally, Tinea pedis, commonly referred to as athlete's foot, produces fine vesiculopustular or scaly lesions on the soles of feet, between the toes, and under the nails. The webs between the 4th and 5th toes are most commonly involved. Peeling, fissures, and maceration appear in severe cases, and pruritus and burning are typically present. Most tinea infections can be diagnosed from the clinical appearance of the lesions. Treatment includes antifungals. For Tinea capitis, topical treatment does not work, so an oral antifungal is used. For the rest, when using topical antifungals, the medication should be used twice a day, and the application of the cream should extend 1 inch beyond the lesion's borders to prevent spread. If topical medication does not clear up the infection, an oral medication can be used. Fungus thrives in warm, moist environments, so it is important to keep infected areas as dry as possible. Teaching proper hygiene is essential for preventing and treating fungal infections. Teach children to avoid sharing personal items such as combs, hats, and hair ornaments. Children with tinea infections should sleep alone and should not share towels or washcloths with others. Feet should be washed daily and kept dry. Advise children to allow their non-ventilated athletic shoes to dry thoroughly between wearing. Heavy cotton socks absorb sweat and keep the feet dry. If Tinea pedis is present, the child should change socks at least twice a day and go barefoot or wear sandals as much as possible. Talcum powder or an antifungal powder applied twice a day might help keep feet dry. If a child showers at school or at a gym, shower shoes should be worn. Tinea cruris, or jock itch, heals much faster if the groin area is kept dry. Loose-fitting cotton underwear should be worn, and athletic supporters and underwear should be washed frequently. The rash should be washed each day with plain water and carefully dried. Soap should be avoided. Scratching delays healing, so instruct the child to avoid scratching the area. Reassure the young man and his parents that jock itch is not related to a STI. Instruct parents to call the physician if the infection has not improved in 4 weeks or if it continues to spread after 1 week of treatment. Reassure parents that fungal infections is not an indication of poor hygiene or neglect. Avoid expressions of distaste or surprise when caring for children with severe alopecia or inflammation. Encourage parents to return the school-age child to school as soon as possible. Please review the purple nursing care box for the child with a tinea infection, as well as the patient-centered teaching box for home care for a child or adolescent with a tinea infection on your own. The home care teaching, again, the big thing is to not share items and to cleanse the area and keep it dry. And then, of course, to take medications as prescribed.